This is Dave Meinhardt in suburban Detroit at the Vattikuti Foundation offices, and I want to thank everybody for joining us around the world for this masterclass that's sponsored by the Vattikuti Foundation and the Association of Gynecological Oncologists of India. We've established an international panel of experts. One of the key ones is Dr. Professor Somashekhar from India, and he's a great friend of the foundation. He's been a mentor surgeon to several Vattikuti fellows. He's active with the Robotic Surgeons Council of India, and sharing his knowledge is what he does best. And so I'm going to turn the program over to him, and he will introduce everyone on the panel today. Thank you for being here.
Thank you. Thank you very much. Hi, good evening. Welcome everybody for this fantastic Vattikuti Foundation Masterclass on hyperthermic intraperitoneal chemo and role of pressurized intraperitoneal chemo PIPAC in ovarian cancer. On behalf of Vattikuti Foundation and Professor Bhandari sir, this wouldn't have been possible had it not been for the foundation. Sitting in the USA, Dave, Giovanna, and Professor Bhandari sir has coordinated this global webinar on a wonderful way. And I especially thank our parent body, the AGOI, Association of Gynecological Oncologists, and my very close friends, President Dr. Vijay Ahuja, and Secretary Dr. Rupinder, and President-elect Dr. Amita Maheshwari. And I, as a Secretary of Indian Society of Peritoneal Surface Malignancy, extend a warm welcome to all of you. I'll just give a very short introduction, the scenario in India, so we can hear from the expert how we can modify it. We know that there is a group of distinct group called as Peritoneal Surface Malignancy, where by far the disease is confined into the peritoneal cavity. Rarely extra abdominal disease is cause of death, but the death usually is cancer cachexia, ascites, peritoneal recurrences, obstruction, not able to maintain nutrition, and the complication. So this is where we have a group where ovarian cancer sits into this. So it makes logic to have a loco-regional treatment in addition to a cytorectal surgery for peritoneal surface malignancy. The whole concept is predominantly this is the site of the disease. And if you can have a good abdominal cavity control, we can achieve excellent overall survival and quality of life. Unfortunately, worldwide epithelial cancer come in advanced stage 3 and 4C. If you look at 5-year survival in advanced ovarian cancer, when you do a best surgery, it is dismal 10 to 20%. That shows there is a big lacunae in the field of this. And this is all the part of the surgery which needs to be done in ovarian cancer by virtue of its spread. The abdomen may look like this, and you can have a tons and tons of disease in epithelial ovarian cancer like this, but it is very rewarding to do a good cytoreductive surgery, the same abdomen with good cytoreductive techniques. After 7 hours, will look like this. No peritoneum, no Gleason capsule, everything in the abdomen, upper abdomen is stripped, and optimal cytoreduction, CC0 is achieved. And when you have such thing, still you have microscopic disease, and 2/3 of them recur. That is where the concept of macroscopic clearance by good cytoreductive surgery and the role of intraperitoneal chemo with or without hyperthermia comes. And if you look back, we have an Indian HIPEC registry for ISPSM, where 2016 epithelial ovarian cancer under 26 centers in India with a follow-up of 6 median years, we could find that, you know, the 30-day mortality in Indian group over 2000 HIPEC for ovarian cancer is 3.6%. And this particular group, when we compared surgery alone with HIPEC, survival curve is significantly in favor of HIPEC in Indian group, where 40% 4-year survival was there when we do a HIPEC, contrary to 25% only if you do a surgery and IV chemo. And in Indian HIPEC registry, we found upfront cytoreduction and HIPEC was better than interval cytoreduction and HIPEC. And when we compared cytoreductive surgery with IV chemo versus port-based intraperitoneal chemo and HIPEC, we found the HIPEC group fared very well, and any form of intraperitoneal therapy, either 6-port based or HIPEC, had the best 5-year survival. In Indian HIPEC registry, this was the group which we had. And among the PIPEC front, we are running 2 randomized control trial, which is registered with the IRB approval and trial registration CTRI. And this is for platinum resistant second line IV chemo versus PIPAC. And I'm going to present the interim analysis of more than 70 to 80 patients recruited in Rome ISSP NEAT, where we found 70% response rate, and the median survival was more than 12 by PIPAC group. And then when we looked at EORTC global quality of life, the score was in favor of PIPAC than the IV, with side effect being negligible when we compare to IV. This has been all published in Plura Peritoneum. So this is the introduction, and this is where India stays. So what more best to have the best leaders in the world headed by the Netherlands unit. And I thank Henk for this, and our close friend, Professor Bakrin from Lyon, France, to take it forward. And I hand it over, and this is the flow of event. So initially, we have Professor Henk, who would speak on OVIHIPEC trial. Then we have Dr. Ruby, who is going to speak on implementation of HIPEC program in ovarian cancer in Netherlands. Then Dr. Lott would speak on OVIHIPEC 2. Then Professor Bakrin from Lyon, France, she's going to speak about the emerging role of PIPAC in ovarian cancer. Then we have Professor Wilhelmine Van Driel, who is going to speak on how to real world scenario we apply. Then we will take all the question and answer session. So I request everybody to put their question and answers in the chat box and the answer section, or at the end of it to ask to specific expert. So I would invite Professor Henk Schroeder, who is MD PhD from University of Amsterdam, and he's a trained by gynecologist, and then he had a PhD training in minimal invasive surgery, and he had plenty of publication, and the leading one is co-authoring as one of the co-PI of OVIHIPEC trial published in NEJM, and his area of interest is training and learning in robotics and HIPEC, and he has done excellent work, and a great friend of India who visits India to train our HIPEC people, and he has done a lot of joint SO and Indian Society meet. Over to you, Henk. Welcome, and thank you for accepting our invitation, and please go ahead.
Well, thank you, Somu. Well, thank you, Professor Somashekhar, for this kind introduction. This is really a global initiative, and I first of all would like to thank the organization to giving our Dutch group the opportunity to present this, and to also to join with the French for the PIPAC part. I think we have a very interesting program for this this afternoon. The first talk, I will talk about the HIPEC 1 trial, and this talk is also part of Wilhelmine van Driel's work, who is the principal investigator from the Dutch Cancer Institute in Amsterdam. She's a gynaecologist there. She will talk later in this masterclass, but she was also the principal investigator of the OVIHIPEC 1 trial. I don't have any conflicts of interest, no financial disclosures to make, and the OVIHIPEC study was partly funded by the Dutch Cancer Society. When you look at the Netherlands, we're a tiny country somewhere in the north part of the global world, and if you compare it to India, we're quite small. India is almost 80 times bigger and has almost 80 times more citizens. However, there is something weird. If we look at the citizens per square kilometer, you can see that the Netherlands is even more crowded than India. And that is what some people, well, probably don't realize, and I didn't realize before I looked up those figures. So this joint venture of India and us is nice. And I would also like to thank the Indian Society of Peritoneal Surface Malignancies and the Association of Gynae of India to make this afternoon possible. I will shortly go to the rationale of HIPEC, but then a focus on the OVIHIPEC 1 trial. And then after this, the other speakers will join, and we'll have a question and answer session at the end of the 5 presentations, because probably a lot of questions which will be answered during one of the presentations, because there will be perhaps some overlap, and we all address other aspects of this issue. So I think if we combine everything, we'll have quite a good view of the HIPEC for ovarian cancer at the moment. When we look at the rationale for ovarian cancer, HIPEC, we go back to the early 90s, early to 2000, when HIPEC was introduced for treatment of metastatic colon cancer. And there was actually a surgeon at the Dutch Cancer Institute who worked closely together with Dr. Van Driel, who was doing research on the field of colon HIPEC. And he was together with Dr. Van Driel on the basis of this trial. And they worked very hard to make this trial starting at that time in 2007. And they thought, well, a high concentration of chemotherapy at the peritoneal surface, that should work, could do something in patients with metastatic peritoneal surface disease. And it could make sense if you address this directly after surgery, because then you have less adhesions or even no adhesions at that time, because all adhesions will be released just after the surgery. So the HIPEC has the great possibility to reach every space in the abdomen. And if you add some hypothermia to it, you can raise the effect of the chemotherapy, and you can have a direct toxic effect of hypothermia on the tumor cells, because the hypothermia induces heat shock proteins and will serve as a receptor for natural killer cells, but also induces a transition to HRD deficiency, and in this way increase the sensitivity for platinum-based chemotherapy. Next to that, it stimulates the penetration of chemotherapy in the tissue because of the heat. And we already knew that time that the IP chemotherapy can improve recurrent-free and overall survival after primary debulking. We knew that from the Armstrong trial. So that was at the start of the OVIHIPEC trial. It was January 2018 when the trial was published in the New England Journal of Medicine. Dr. Van Driel as first author and principal investigator. The trial was done in 8 hospitals in the Netherlands. There were all cancer centers who are already performing HIPEC procedures for colorectal cancer. And they worked closely together to complete the inclusion of the OVIHIPEC 1 trial. When you look at the study design, it was a randomized multi-center open label phase 3 trial. And the patients were FIGO stage 3 epithelial ovarian cancer patients. And the patients had to be inelectable for primary cytoreductive surgery because of the extent of the disease. So that was usually decided on a multidisciplinary tumor board meeting. And from that on, the people were scheduled for 3 cycles of carboplatin and paclitaxel. And after 2 cycles, there was a response evaluation done by CT and laboratory. And then if there was a stable disease or a response, they were scheduled for the interval cytoreductive surgery. And then 245 patients were finally randomized for this study, 1-to-1, and they were randomized at the moment of surgery. So we opened up the abdomen, we checked the whole abdomen, decided the PCI score, and we decided if we can debulk this patient complete or optimal. If that was the case, then on the OR, the randomization was done, and we were randomized if we should add the HIPEC or not at that time. After the surgery and the HIPEC, patients got all 3 cycles of carboplatin and paclitaxel again to complete their treatment. Then we had primary endpoints. We had recurrence-free survival, and secondary endpoints, overall survival, safety, and quality of life. Follow-up visits were performed every 3 months for the first 2 years, and then every 6 months thereafter, with routinely CA-125 was measured. And also at some stage tumor CT scans were done, and they were performed at 26, 52, and 104 weeks after the last chemotherapy. And also we used the CTC grading system for grading the toxicity of the treatment. The technique of HIPEC we used was the open technique, and it was directly following the interval cytoreductive surgery. We used the 3 inflow drains, and we used 2 outflow drains for continuous circulation, and we used cisplatinum 100 milligrams per square meter. The temperature was kept between 40 and 41 degrees, and we used sodium thiosulfate to protect renal function. Perfusion was always exactly 90 minutes done. So this is how it looks like in the OR. We built in the retractor, we built like a coliseum. We lift the abdominal wall, and then we fill the abdomen with fluid using 3 inflow and 2 outflow drains. We use temperature measurement in every quadrant of the abdomen, and then we cover the coliseum during the perfusion to reduce the loss of heat. The patient inclusion took about 9 years, which was a long time, and it was longer than expected. As I just said, we randomized during the procedure, and one of the reasons that it took some time for the recruitment was that there was no financial reimbursement for the HIPEC procedure at that time. So there was no insurance paying for it, and the hospitals who participated paid the treatment themselves. And some hospitals had a restricted amount of procedures a year. So it took longer than we expected, but we completed to fill the study. When you look at the baseline characteristics, there was no big difference between both groups with respect to age, histology, the order of treatment, primary chemotherapy or suboptimal debulking, but also for the numbers of regions affected at start of the cytoreductive surgery, which were similar in both groups. When we look at the surgical results, we see we reached almost 70% complete debulking, and all the surgeries were done together. The gynae oncologist and the surgical oncologist worked closely together in all these patients. And if you add the miliary disease, we reach almost 90%. When we look at the post-operative characteristics of the patients, we see that the operation was longer. That's for sure. You lose 2 hours, 90 minutes for the perfusion, and half an hour breaking up and setting up the system. And then there was an admission for the ICU that was protocolized. So all the patients had to be admitted for 1 day at the recovery or at the ICU. That was written in the protocol for extra monitoring. And then the overall total admission time was added in, was 2 days longer than the cytoreductive surgery without the HIPEC. The restart of chemotherapy after the surgery was no different, and also the schedule afterwards, there was no difference. When we look at the toxicity according to the grading system, then we were surprised that we didn't see any significant difference. There was an even distribution in both arms between the cytoreductive group and the HIPEC group. And also, if you look at the grade 3 and grade 4 toxicity, you can see that the different toxicities, that there was no significant difference between the groups. Also for the quality of life, there was no difference between both groups, not after the surgery directly, but also not after completing the treatment, but not after a few months. There was still no difference between both groups. We found a difference, however, in the formation of colostomies. When you look at both groups below, you see that the rate of bowel resections in both groups were the same. In both groups, there was 24% of bowel resection. However, if you look at the stoma formation, you see that there was 72% of the bowel resections patients got a colostomy in the HIPEC group, and 43% in the non-HIPEC group. So perhaps the surgeons, we decided to be a bit more careful and make a bit easier a colostomy in the HIPEC group, because another explanation we really don't have at the moment. Then at the end, if you look at the progression-free and overall survival, you see a gain for the HIPEC group in the progression-free survival of 3.5 months. And for the overall survival, you see a gain of 12 months. So the data are also consistent for the predefined stratification factors, like one of the 8 institutes, the previous surgery, or the number of involved abdominal regions. So in conclusion, we found that for patients with FIGO stage 3 epithelial ovarian cancer treated with neoadjuvant chemotherapy, adding HIPEC to interval cytoreductive surgery prolongs the progression-free survival with 3.5 months and the overall survival with 12 months. And this without adding a significant difference in toxicity or quality of life. So that was very interesting. And we in the Netherlands, we decided to make this possible for our patients. And our next speaker will talk about this issue. That's Ruby von Stein, because we decided to implement this treatment for all our patients, and we implemented at one stage on 1st of March in 2019 in all centers at once. And we arranged that it was reimbursed now by the insurance companies. So all people in the Netherlands have the availability to receive this treatment. We would like to thank all patients and their families and all participants, doctors, nurses, and everything. And we would like to thank you for your attention. As said before, we will raise the questions at the end of the presentations, because the other presentations will add up to this. And at the end, a lot of questions probably will already addressed during all the other presentations. Well, thank you for now, and we speak to each other later today.
Thank you very much, Henk, and that's a fantastic presentation. We all know that this trial actually changed everything in the world. I just remember I used to go to Canadian Society of Gynae-Onco, and all they used to ask me was robotic. Once your team, everybody presented this, when I went to give an oration there, all they were asking is HIPEC. And this particular trial made NCCN actually recommend and cropped into their recommendation, and this changed everything. As you said, the question and answers will be taken. I'm keeping an eye on the chat box. Already a lot of questions are coming for you. I'm going to compile them. We can spend good time at the end of all presentation to answer all of them, because many times a question asked could have been answered by the next speaker. Thank you very much for that wonderful talk. The next particular talk is from Dr. Ruby Stein. She's from the Department of Gynecological Oncology, Netherlands Cancer Institution. And we will run the presentation, and thank you, and word to that, please.
Good afternoon. My name is Ruby van Stein, and I'm a medical doctor and a clinical researcher in the Dutch Cancer Institute, Antonie van Leeuwenhoek Hospital in Amsterdam. First of all, I want to thank Dr. Schreuder and Professor Somashekhar for giving me the opportunity to tell you all something about the implementation of HIPEC in the Netherlands. Unfortunately, I am unable to attend this meeting So that's why I pre-recorded this video. If you have any questions, please ask Dr. Van Driel or Dr. Aronson during this webinar, or otherwise send me an email after this webinar. Dr. Schreuder gave a presentation about the OVIHIPEC 1 trial, and I will briefly show you the survival curves since this trial is the basis of the implementation project. Patients with ovarian carcinoma stage 3 eligible for interval cytoreductive surgery were included in this trial. The results were positive. The trial showed a significant improvement of recurrence-free survival of 3.5 months and overall survival of 12 months with the addition of HIPEC. There was no significant difference in complications or adverse events, and besides no significant difference in quality of life between arms. Following the publication of the OVIHIPEC 1 trial, the national guidelines were adjusted, and HIPEC was approved by the health authority, so financial reimbursement by health insurance was obtained. This brought us to the implementation of OVIHIPEC with the purpose that every patient with advanced ovarian cancer eligible for this treatment will be offered HIPEC in the Netherlands. Just starting with performing the procedure is not enough. There are many goals during an implementation process. In this particular case, you can think about that HIPEC should be public and accessible to all eligible patients in the Netherlands. HIPEC is nationally promoted to patients, but also to committed healthcare professionals. Clinicians should have expertise and knowledge about HIPEC, and steep learning curves for each hospital executing this procedure will be ensured. Quality of life of patients will be guaranteed. That's very important. And ideally, debulking surgery with HIPEC is performed on a comparable basis across the country, with minimal differences between centers. Besides, by standardizing treatment, complication rate will be low. This is well examined in the surgical community with HIPEC for colorectal cancer. The Dutch Cancer Institute introduced cytoreductive surgery with HIPEC for colorectal cancer in 1995. The treatment protocol was determined in a phase 2 study and tested in a phase 3 study. After completion of this trial, the protocol was refined and implemented in the Netherlands. That was approximately in 2003. In 2005, the protocol started in a second hospital, and more hospitals followed in subsequent years. So 3 phases can be identified. The first 100 consecutive CRS HIPEC procedures, that's the pioneer phase, shown in the middle column of this table. The implementation phase started after a completion of the trial and took a few years. And then the 100 most recent consecutive CRS HIPEC procedures, that is the control group, and that's the last column. What they saw in conclusion was a major decrease in morbidity ever since the Dutch HIPEC protocol, standard Dutch HIPEC protocol for CRS and HIPEC was implemented. In addition, the amount of incomplete site reductions decreased. The new HIPEC centers managed to have similar outcomes as the experienced center, indicating that the standardized protocol was a safe guidance for opening a new HIPEC center. And what you can conclude in general is that the implementation of a standardized treatment protocol could result in safe procedures and reduced complication rates. This is also known from aviation studies that deviation from a standardized procedure can be dangerous and can cause accidents. Back to ovarian cancer. On this slide, I would like to present the current situation in the Netherlands. After the completion of the OVIHIPEC 1 trial, a cost-effectiveness analysis was performed, which showed that interval cytoreductive surgery combined with HIPEC is cost-effective for this patient population in a Dutch or comparable healthcare system. In 2018, the Dutch health authorities approved full financial reimbursement for OVIHIPEC. The national evidence-based guidelines were updated and adjusted with respect to the role of HIPEC for ovarian carcinoma. Patient organizations were involved in these processes and support the implementation of this treatment. In the Netherlands, we have a high level of organization of care for patients with ovarian malignancy, resulting in centralized care for these patients. In each of the 8 regions, 1 or 2 selected hospitals are implementing HIPEC for patients with ovarian cancer, resulting in 10 HIPEC centers in total. In the next slides, I will take you through the actions which we already performed or which we are currently executing. In November 2019, we organized an OVIHIPEC symposium in the Antonie van Leeuwenhoek Hospital. This was the kickoff of the implementation project. We invited all members of the Dutch HIPEC teams, involving gynecological oncologists, surgeons, medical oncologists, anesthesiologists, nursing staff of the ward and of the theater staff, since they all plan an essential part in the pre, per, or postoperative treatment. This was a very successful event, and as a result, all the HIPEC teams were on the same page with respect to the desire to fully implement HIPEC in the right way. The next action is about training. Of the 10 centers performing HIPEC at the moment, 8 already had experience with HIPEC for colorectal cancer and participated in the OVIHIPEC 1 trial. They could easily adopt the HIPEC procedure and contribute to the implementation. The 2 remaining centers were trained by one of these 8 centers. Originally, we had the plan for a rotational program to visit and train each center in real life. The idea is that every OVIHIPEC center is visited by a team of another center at least one time. Unfortunately, up until now, this was impossible due to COVID, and hopefully we can start this up in 2022. As explained earlier, it is desirable to fine-tune and standardize the OVIHIPEC protocol. This will minimize practice variation and will ensure that all patients receive optimal and safe treatment. A survey was conducted in 2019 among Dutch cancer centers performing HIPEC for ovarian cancer. Differences existed regarding patient inclusion for interval CRS and HIPEC, regarding technical aspects of the HIPEC procedure, and regarding perioperative management. As part of the Dutch implementation process, we aim to standardize these important topics using a consensus-based approach. Multiple video brainstorm sessions were organized in which topics reflecting the essentials for pre, intra, and postoperative care were defined. Following this, a Delphi method is used to reach expert-based consensus on these topics. 40 multidisciplinary experts were involved in this consensus. At the moment, we are in the final stage of the Delphi consensus. It is important to assess the outcome of this newly implemented treatment. The results will be carefully evaluated since all data will be entered in a Dutch clinical audit, the DGOA. This is a nationwide clinical audit in which all hospitals will enter all data from patients treated for gynecological malignancy. These data give details on results of the treatment. On a yearly basis, these results are analyzed and reviewed. The aim is to investigate the application and effectiveness of HIPEC in clinical practice. In this way, the external validity of the research results of the OVIHIPEC 1 trial will be investigated. We have a few research questions. What are patient tumor and treatment characteristics of patients undergoing interval debulking with HIPEC compared to patients undergoing interval debulking without HIPEC? This hopefully enables to answer the question, did all eligible patients receive HIPEC after implementation of this new treatment? What are the clinical outcomes, for example, surgery duration, blood loss, etc., after HIPEC since implementation in the Netherlands compared to clinical outcomes during the OVIHIPEC 1 trial? And for example, is there a difference in the first year of implementation compared to the third year in implementation? And last, what is the recurrence-free and overall survival of patients since implementation, and how does this correlate to the OVIHIPEC 1 trial? I would like to end with some future perspective or future goals. Hopefully after an implementation phase of 2 to 3 years, all the goals that I mentioned earlier will be reached. As sort of side effect, it may be possible that this implementation project might lead to a higher percentage of complete site reduction, since there is a closer collaboration with surgeons. And this implementation process might help to improve the quality of the OVIHIPEC 2 trial, examining the value of adding HIPEC to primary CRS. Dr. Aronson will tell you more about it later. As you can see on this slide, the implementation project is a close collaboration with hospitals, patient organizations, funders, trial groups in the Netherlands. It's a collaboration of which we are very proud, and we would like to thank everyone being part of this project with the ambition to improve outcome for patients with ovarian cancer. I would like to thank you for your attention. Goodbye.
Good talk. We all know in India, starting a HIPEC program is one thing, but able to implement a successful program in real world among the patient is a tough thing. We could take a cue from the Dutch group, how they implemented it. That's an excellent talk, and a lot of questions are available. And then what I will do is, as we decided, I'm compiling all of them, and then we would actually at the end of it go ahead. So we are going to go to next talk, and I welcome Dr. Lot Arson, who is an MD, and she's working in the Department of Gynecological Oncology in Netherlands Cancer Institution. She's a researcher, and she's studying the implementation of HIPEC in ovarian cancer. She has a master's in medicine from Leiden University, and she also has a master in transplantation from Rotterdam. Thank you very much for accepting our invitation, and we're looking forward for your talk. Please go ahead.
Thank you for the introduction. Thank you for the very kind invitation to speak at this webinar. My name is Lot Aronson, and I'm a medical doctor and clinical researcher at the Netherlands Cancer Institute. And together also with my colleague Ruby van Stijn, who you just heard giving her presentation, I'm the study coordinator of the OVIHIPEC 2 trial. So I would like to introduce to you this second trial that's currently recruiting patients since the 1st of January of 2020. So we've already heard a lot about the OVIHIPEC 1 trial and its results and its implementation in the Netherlands. And of course, its benefits for patients with ovarian cancer. And in this second trial, we investigate whether these advantages also apply to women undergoing primary cytoreductive surgery. So that's a different patient population. The patient population consists of patients with stage 3 ovarian cancer who are eligible for primary CRS. And then we will compare the addition of HIPEC to CRS without HIPEC with primary outcome of overall survival. Here you can see an overview of the study design. It's a little bit similar to the OVIHIPEC 1 trial, but there are some differences. In the first box, you see the patient population. So as I just said, stage 3 ovarian cancer. Patients can only be randomized if the complete cytoreductive surgery was achieved or with residual disease to 2.5 millimeters. Patients should have a performance score of 0 to 2. And the randomization will be done at the end of the cytoreductive surgery. Patients are randomized 1-to-1 to HIPEC or no HIPEC, and all patients will receive 6 cycles of carboplatin and paclitaxel. Carboplatin is administered every 3 weeks, and paclitaxel either every 3 weeks or a weekly scheme. Also, if there's an indication for PARP inhibitors or bevacizumab maintenance therapy, that's also allowed in our trial. Follow-up for this trial will take 5 years. In the first 2 years, every 3 months, and in the last 3 years, every 6 months. And we will perform tumor assessments by monitoring the CA125 and performing CT scans and physical examinations. So the difference with the OVIHIPEC 1 trial is that randomization is performed at the end of the CRS instead of upfront to surgery. So during the CRS, the surgeon or gynecologist doesn't know the outcome of the randomization yet. In this trial, both the open and closed techniques are allowed. So as we showed earlier on the right, you see the Colosseum technique, the open one, and on the left you see a kind of a cartoon of the closed technique. We use cisplatin in a dose of 100 milligrams per square meters, and sodium thiosulfate is used to protect the kidneys. The next slide is about the sample size calculation. We have calculated a total sample size of 538 patients. And we used the following factors to make this calculation. We used the estimation of survival of the control group from the Armstrong study that was published in 2006. That's almost 50 months. The efficacy of HIPEC was determined in the OVIHIPEC 1 trial with a hazard ratio of 0.67 and a study duration of 6 years. And this was a condition of the Dutch funder of the trial. Interim analysis will be done after 67 and 133 events. And all of this together results in a patient total of patients of 538. And the primary analysis will be done after 200 events. And an event is death of all cause. Estimated accrual time will be 5 years and 1 year for follow-up of the lost patient. Here I will show you 2 of the most important inclusion criteria for this trial. So the stage 3 primary epithelial ovarian cancer should be histological proven. Sometimes that's not possible before surgery, but then intraoperative frozen section material is also a way to prove this. There are some patients with stage 4 disease that we also allow in this trial. And that's, for example, when there's resectable local bowel involvement, abdominal wall metastases, or umbilical lesions. In case there is a sign of extra abdominal enlarged lymph nodes, the protocol says to either do pathology or a PET scan, which must be negative. And the second inclusion criteria that I would like to show again is that a complete or near complete surgery should be achieved. So only when there is no residual disease or residual disease up to 2.5 millimeters, then we will randomize the patient. Here you can see some of the exclusion criteria. For example, history of previous malignancy treated with chemotherapy, and there are some exceptions for this. For example, basal squamous or squamous cell cancer of the skin. And also we allow if someone had a malignancy more than 5 years ago, and if this wasn't treated with chemotherapy. And of course, if primary site reduction is not feasible, then enrollment in this trial is not possible. And for this, we use the trust criteria to make this decision. This trial is supported by the GCIG and NGOT, the International and European Intergroup Societies for Gynecological Oncology. So it's an inter-trial group collaboration. And on this slide, I would like to show you our international collaboration. So here I show the trial groups, but I will explain which countries they are. So in the first line, you see the Dutch oncology group. We started patient accrual January last year, and 10 hospitals in the Netherlands are participating in the trial. The second one is France. They already started patient accrual in November last year, and they are now open with 3 centers, but they will extend until 10 hospitals. Then Italy and Scandinavia. In Scandinavia, Denmark and Sweden. We expect them to start accrual in June of this year. I see here it says that NSGO has started in June 2020, but it should be 2021. And Memorial Sloan Kettering Cancer Center in New York and Cancer Trials Ireland are expected to start accrual in September. The UK and Australia are also have started funding application, and they are planning on opening the trial in those countries too. Well, what is the current status of the trial? We have randomized 30 patients of the 538. COVID-19 has definitely had an impact on the trial progress and the patient accrual. As you can see, from March to June last year, the trial was on hold in all participating centers. That was during the first wave in the Netherlands. But after reopening, we gladly see increased numbers of accrual, and we are confident that we can reach the total number of 538 with the international collaboration that we're starting. However, to ensure surgical quality of this trial and to prevent that multiple sites will participate with a low accrual numbers, we set some criteria for centers that show interest to participate in this trial. And here you can see those criteria. So the first one is that the center should be a member of a national trial group because it's an inter-trial collaboration. A center should have performed 20 cytoreductive surgery procedures per year for ovarian cancer. It should be an experienced HIPEC center. So we set the criteria that they did 10 HIPEC procedures before start of accrual. There should be a multidisciplinary team in the hospital consisting of a gynecological oncologist, medical oncologist, pathologist, radiologist, and often gastrointestinal surgeons to do the procedure together. And center must have own financial resources for the study treatment and be experienced in conducting clinical trials. So for example, have a clinical trial department for organizing all the study assessments. You have seen this slide earlier, but this is a more extensive one with the international collaboration. So this trial could only be realized because all of these hospitals, trial groups, funders, and hospitals are joining us in realizing this trial. So I would like to thank everyone that's doing its very best to make this a success. I would like to thank you, of course, for your attention and for the questions. I'll be there at the end.
That's a most interesting and eagerly awaited trial. Because you know that everybody want to jump into HIPEC in upfront setting in primary cytoreductive surgery. And the final proof of pudding of HIPEC is this trial. I think not just gynecologist, oncologist, all the colorectal, pseudomyxoma, mesothelioma, everybody is waiting for this trial. That's fantastic for devising this trial, and hopefully we hope we'll have the results soon and you'll have an excellent outcome. Thank you very much.
As soon as possible.
There are a lot of questions. I'm going to put it to you at the end of it. Hundreds of questions have already come in. So as we decided, we move to next topic, and then at the end of the entire thing, then we are going to take all the questions. So the next speaker for us is our close friend, Professor Bakrin. She's a great scientist. She's a consultant gynecological oncologist, peritoneal surface malignancy specialist, and she works in Lyon, France, in the University Hospital. If you go back and see all the publications international in the field of ovarian cancer that is coming, from that hospital, it's all, the primary author is Professor Bakrin. She has several publications to her credit. And if you go to ResearchGate and log in and look at the RG score, she has very high RG score. That shows that her work is quoted, re-quoted, and published again and again. She is an excellent orator, great scientist, and a good friend of ours. She's also in the mentor and mentor group of ISSP, who devises various modules in the PIPAC. She's an expert in the field of PIPAC as well as HIPEC. And she's one of the main investigators who is now analyzing the global role of PIPAC in ovarian cancer, along with a group of people. And she's going to come up with the final result and analysis. Thank you very much, Professor Bakrin, for accepting our invitation. I know there are tough times and the blackout there, I think the way that would happen is they would run your presentation, and you can actually give an audio through your phone. And whenever you want to move the next slide, please tell Dave so he would move it. Is that okay? So Dave, can you please run the presentation? Over to you, Professor Bakrin. Thank you very much for accepting again.
Hello, Dr. Bakrin. This is Dave. I do have your first slide up. I hope that you will be able to connect with us.
With your phone, I think there was unfortunately a blackout in that whole town, and then so she couldn't log in with any computer. She logged in with her phone. Professor Bakrin, can you hear us? Your first slide is on, and can you please go ahead?
It does look like we're having difficulty connecting with Professor Bakrin right now. We apologize for this difficulty. Every once in a while, technology does get the best of us, and we hope we can connect with Professor Bakrin. If one of our other panelists would like to maybe answer some of the questions in the Q&A right now while we're trying to reconnect, feel free to do that. This is Dave Meinhardt in Detroit, the Vattikuti Foundation. Once again, I do apologize for the difficulty we're having with our Zoom connections. There's apparently been some kind of a power issue in Lyon where Dr. Bakrin is. And once again, if one of our other panelists would like to begin.
Dave, I just spoke to her on her mobile, and she's just trying to re-log in. Maybe we'll wait for about 15-20 seconds.
Okay.
Yeah, she's connecting, so then you can play the slide. Welcome, Professor Bakrin. Can you hear us?
Yeah, I'm very glad you give me the opportunity. I have some troubleshoot with my internet connection, so I will do my best, and I'm trying to be quick to give you my message. Hopefully, you hear me clear.
Yes, we can hear you. Please go ahead.
It's okay for you? Thank you very much. So you told me to talk about the emerging role of PIPAC in ovarian cancer, and it's a very exciting topic because the PIPAC is a new technique, and indeed, I think that ovarian cancer is a wide field of research for PIPAC. So next. You all know that epithelial ovarian cancer is not, we can consider it as a rare cancer, but there's a lot of death every year. And you know that even if you give to the patient the best surgery with no tumor, perfect surgeries, sorry, and the 6th cycle of chemotherapy recur within 5 years, and this will be a problem to treat them afterward. Fortunately, the natural history of the ovarian cancer is mostly peritoneal, and this makes it perfectly suitable for local regional approach. Next one. So PIPAC, I think that everybody know what is PIPAC here in the audience. PIPAC, it's only a new way to give chemotherapy. I think we don't have to compare it to HIPEC of a very the last step of the surgery, whereas PIPAC is the repeated IP chemotherapy. The standard procedure for PIPAC is as follows. The patient is under general anesthesia. We put 2 trocar that are inserted in the midline, and then we do a capnoperitoneum that is maintained with 12 millimeter of and then we put a nebulizer and the laparoscope in each trocar. And maybe we can use a 3rd trocar if we have some trouble or some technical difficult cases. Then we explore the abdomen, and once we have described the peritoneal carcinomatosis through the PCI, we may have a biopsy if needed, and then we inject through a high pressure line the chemotherapy. So this is the way we give PIPAC to our patients, and this technique is repeated through a particular agenda, considering the disease. Next one. So you can say that IP is not a new idea. It's not a new way to give chemotherapy, and we perfectly know IP in ovarian cancer, particularly in adjuvant setting. And we know that IPC were proven to improve PFS and OS. So I give you this this well-known Cochrane review concerning IP, and you can see that there is an improvement of PFS and an improvement of OS for a patient with ovarian cancer. But the real problem in IP was the GI toxicity, the pain, the fever, and the catheter-related complication that made IP not be a standard treatment, even if there was a benefit for patients. So considering this data, next we could just ask what is the benefit, the advantage of PIPAC compared to IP. Next one. So the difference, you can see it on the next dia. When you give IP, you don't have a high concentration of chemotherapy, and this is a photography of the abdomen of a pig. Next, you can see the difference between IP distribution and PIPAC distribution. Since in PIPAC, chemotherapy is not diluted, and then it is given with a high concentration, and it present a better distribution compared to IP chemotherapy. However, the last studies that were published in PIPAC show that even if the distribution is better than IP chemo, there is a heterogeneous distribution of the penetration of doxorubicin. We see that the nebulizer than in tissues that are located in the opposite top or side wall after PIPAC. Anyway, PIPAC has a better distribution than IP. Next. in the next dia, you can see the view of the distribution of blue colorant given by the nebulizer, and this is a view of the laparoscopy, and you can see that every part of the abdomen, the peritoneal wall, and the organ are quite homogeneously there is a quite homogeneous distribution of the chemotherapy. And this perioperative consultation, we can have a confirmation of this efficacy, of this biological efficacy, when we look at the tissue penetration. Next, since the penetration of the chemotherapy when it is given by PIPAC is up to 7 layers, that is that is better than HIPEC and better than the control. Maybe I think that that results are due to the fact that PIPAC is distributed with a high pressure, whether compared to HIPEC, that in most of teams, HIPEC is given according to an open procedure, so without any pressure. Anyway, PIPAC allow a better penetration of chemotherapy inside the tissue. Next, if we look at the chemotherapy regimen, actually the team that practice PIPAC all over the world try to have a very homogeneous practice and not to fall in the pitfall that we felt in HIPEC with very heterogeneous protocols. So we all try to give the same protocol to our patients, and the last one, next dia, is based on the PIPAC OV2 prospective open phase 1 dose escalation that concluded that it was safe to give cisplatinum a B therapy with cisplatinum 10.5 milligram per meter square and doxorubicin 2.1 milligram per meter square. Even if there is some heterogeneity among the team that practice PIPAC, I think that most of us use either this protocol, either the previous one that was cisplatinum 7.5 and doxorubicin 1.5. So this is for the PIPAC protocol. Next one. If we look to the safety and the feasibility of PIPAC, we have 14 studies that can be looked at. We have up to 70% of non-access rates. Since we usually treat patients that have already been operated on, this raises a concern concerning the ability to give them the laparoscopy, to access to their abdomen. Historically, we say that there was about 70% of patients that couldn't have the PIPAC because of a non-access of non-access. But the more the team are trained, and the less we have to face up with non-access laparoscopy. So I think that for training teams, we are about 3 to 5% of non-access rate, rather than 70%. So there are some grade 3 to 5 toxicity from 17 to 33%. It may appear a lot high, but we will see later in the presentation that they are not. It is nothing to. It's quite different from the toxicity of surgery in HIPEC. And the mortality in some articles are reported to be up to 6.8%, and this has to be put in perspective that in most of these studies, we treat patients in palliative intent. So we have to keep this in mind, that when there are mortality, we have to keep in mind that some of the patients were treated in palliative intent. Next one. Concerning PIPAC and ovarian cancer, if we check all the literature, we can see that more than 2/3 of the patients with ovarian cancer are treated for recurrence. Probably because this subgroup of patients don't have standard treatment, and mostly they present platinum resistant recurrence with the well-known poor outcome we all have to face with. Concerning the clinical efficacy, I will only talk about the PCI and the pathologic response, because when we read all the literature about PIPAC and ovarian cancer, I don't think that the overall survival on the PFS can be interpreted because there are small series or there are retrospective series that in the beginning, we have to focus on the clinical efficacy, but on the macroscopic and the pathologic response. In TEMFR 2015, the number 24 and 25, you can see that there is an improvement of the peritoneal carcinomatosis rated through the PCI that is between 15 to 75%. And when we focus on the pathologic response, we can see response between 15 to 70% of improvement of the pathologic response. This pathologic response include the complete response, the stable disease, and the partial response. So this may be seen as promising results, but we don't know if this is reduced by a better OS or better PFS. These are, for the next dia, we can see the intraoperative finding. When we perform 2 or 3 PIPAC in patients, these are the aspects that we face up once we have performed the laparoscopy. Next dia, please. So these are the laparoscopy before the first, before the second, and before the third pressuride, before the third PIPAC. And you can see that what appear is the sclerosis of the peritoneal nodule. And we can see that the nodule shrink from the first to the third PIPAC. Let's go to the quality of life. Next dia. So this was the intraoperative finding, real sclerosis of the tumor, and then the quality of life. In a palliative intent, PIPAC seems to be able to maintain or improve the quality of life of patients with peritoneal carcinomatosis, and particularly in patients at end stage. And we can see in particular that the gastrointestinal function through nausea, vomiting, loss of appetite, diarrhea did better through PIPAC. And there is no deterioration of the physical or the emotional function. So this has to be kept in mind because if we consider this particular subgroup of ovarian cancer that are in palliative intent, the fact that the quality of life is improved or at least stable is a good point for PIPAC. Next dia. So in the next slide, I just wanted to focus on the epithelial ovarian cancer and the way it responds to chemotherapy. First, you can see that I don't evaluate, I don't assess the number of upfront surgery, because all surgeons and oncologists know that the rate of frontline surgery is not all about the resectability. It depends more on the surgeon, on the center culture, and that's why I focus on the patient with neoadjuvant therapy, whatever the rationale is. You can see that if you take into account 100 patients that you treat with chemotherapy first, 15% of the patient will receive 3 chemotherapy and respond enough to go to the surgery, and then they will be given 3 more chemotherapy. So there are the good responder, the one who respond enough to be operated on. And then there are 45% of patients that do receive 3 cycles of chemotherapy, that do respond, but their response is not enough to give them surgery, and so they don't have a resectable disease, so they go on 3 more chemotherapy. This subset of patients is, I think, a group of patients we have to find them some solution for treat them better, because we don't know if we operated on after 6 cycles of chemotherapy, is this surgery will give them a benefit on survival or not. I think there are not up-to-date strong data on this. And finally, there are 5% of patients that have a refractory disease, and these have a very, very poor outcome. There is not a lot of solution for these patients. So if we focus, next slide, if we focus on the platinum-resistant recurrence, you know that they have a very poor outcome. 6.7 months since the Aurelia protocol, and for the OS, it's almost less than 1 year. So they are treated with a single agent chemotherapy with non-platinum drugs, so they are not challenged another time with platinum. And we know that the combination of additional agents doesn't offer any advantage for this subgroup of patients. The addition of bevacizumab in the Aurelia protocol increased the PFS, but with a high risk of complication. So there is no guideline recommendation for a single regimen, and most of the time, the therapeutic decision is left to the physician. We always say best physician choice. So it's a population of ovarian cancer with a very poor outcome. If we consider the second, the third, and the fourth recurrence, I have cleared the first recurrence because with the olaparib and the new treatment, the outcome have radically changed and improved. But if we considered the third and the fourth recurrence, we can see that the outcome dropped with the more there are recurrences and the more the outcome drops, and the response of the chemotherapy drop also. Next slide. Next. So you can see for the third recurrence 9 months, until for fourth recurrence 5 months. And if we consider the survival, you can see that the PFS gain is only 3.5 months for the patient receiving relapse treatment, both in third and fourth line therapy, compared with patients without any treatment. I don't say that chemotherapy isn't useful. I think that chemotherapy is absolutely necessary in ovarian cancer, but the higher line of subsequent systemic treatments may be less beneficial for the patients, and maybe also more toxic for patients that have already been challenged, whose bone marrow had already been challenged with previous line of chemotherapy. So all this all this data has to be taken into account when we consider treatment for this subgroup of patients with a poor outcome. Next slide. If we focus on the clinical endpoint on the patient-reported outcome that are a growing interest in our field of research, we can see that when they are asked for their opinion concerning a new agent, they think that to be meaningful, the minimum extension of PFS and OS should be 5 months, according to women with ovarian cancer. And they are willing to accept a shorter PFS to avoid severe side effects. This is very important, particularly in the 3rd and the 4th recurrence. And they are prepared to accept a higher toxicity only if they are promised to have a longer OS. And this point of view is very important to build our future clinical trial and to respond to answer to the need of our patients. Next slide. I wanted to focus on the PIPAC OV1 safety. PIPAC OV1 is a phase 2 trial of PIPAC in patients with ovarian cancer, recurrent and platinum resistant. And I wanted to focus on the type of toxicity, because when we talk about the toxicity of PIPAC, you can see that indeed you have grade 2 and grade 3 toxicity, but this kind of toxicity is mostly abdominal pain. It's a bowel obstruction, but transient bowel obstruction, sometimes intraoperative bleeding, and most of the complications are inflammatory due to the IP chemotherapy. So even if I told you that there was 33% of grade 3 and 4 toxicity in PIPAC, it's definitely not the same complication that we see in surgery and HIPEC. Unfortunately, it's not the same because it's not the same population. When we consider surgery and HIPEC, it is with the curative intent, while when we consider PIPAC, we at this stage of our knowledge, we consider it only in a palliative intent, or at least not in a curative intent. Next slide. So, in my opinion, what are the PIPAC perspective? What we can say is that there are 3 groups of patients that have their therapeutic needs that are not met. The platinum-resistant recurrence that don't have any standard unless the monochemotherapy, the higher relapse for third and more, and I give also a rule for PIPAC in the non-resectable disease, because for these patients that maybe would benefit from a surgery, I think that it may have it may be a place, a role for PIPAC to intensify intraperitoneally the treatment and to make these patients being good candidates for surgery. So I would say there are 3 populations: non-resectable disease, platinum-resistant recurrence, and third relapse that would be good candidate for the PIPAC perspective. And indeed, when we focus only on the trial that address ovarian cancer, because there are a lot of trial in PIPAC and ovarian cancer, but also when they are met with other peritoneal carcinomatosis etiology. There is PEROT, that is a phase 1-2 that address the patient with peritoneal cancer with ovarian cancer with the recurrence, platinum-resistant recurrence. Next slide. And there is a PIPAC OVA that is a phase 1 trial that addresses the patients that are not resectable after 3 cycles of chemotherapy, and that will be intensified will have an IP intensification with PIPAC to make them resectable after 3 more cycles. Next slide. I think that there is also a place in PIPAC for patients, for elderly patients that have more than 75 years, and also for the comorbidity. If you look to this very interesting study of the German Quality Assurance Program that look at the outcome of patients that have ovarian cancer, you can see that considering the 75 years and more, and considering the patient with comorbidity, and considering both, it's to say 75 years plus comorbidity, these patients, next please, these patients represent more than about 12% of all patients. So it is a huge amount of patients that are not given the complete treatment. And moreover, next, if you focus on the survival, you can see that at 3 months, there is a mortality rate of 30%, and at 6 months, there is a mortality rate of 40%. And this is the results for this 12% of patients that are treated with the actual standard. It's to say chemotherapy and surgery. And maybe we have to think about an alternative to these patients that obviously the standards are not fit for, they are not fit for the standards. It's the contrary, they are not fit for the standards. Next slide. So if we complete, I think that the PIPAC perspective we can distinguish 4 populations for which there are unmet therapeutic needs: the non-resectable disease, and maybe we could imagine that there is a place for combined IV and IP therapeutic. The platinum-resistant recurrence, maybe to sometimes give them some and to make them hospital, since PIPAC is given every 6 weeks. So platinum-resistant recurrence could be given exclusively PIPAC, but all this suggestion has to be assessed inside a trial. Maybe for the 3rd and more relapse. And I think that the elderly are an ideal population to study PIPAC, the effect and the efficacy of PIPAC in. So thank you very much for your attention. I hope that you hear me, you have heard me clearly, and I give you the main message I wanted to. Thank you very much.
Thank you very much, Professor Bakri. That was a wonderful, excellent evidence-based talk. The concepts and the way forward, which has been explained and put by you, are outstanding. I know that you are just presiding over the data of all the PIPECs done in ovarian cancer globally. And the next couple of months, you're going to come with a publication. We are eagerly waiting for that. Personal thank you in these difficult times, when you had a blackout there, and when you had a lot of technical problem, you could really do everything fantastically through your mobile. Yeah. Please don't leave, because a lot of questions have come pertaining to your talk. Thank you very much, and we will start the next talk, and which everybody has been eagerly awaiting. I welcome Professor Dr. Wilhelmine Mandriel. She is Professor of Gynecology, Oncology, and Peritoneal Surface Malignancy Specialist in Dutch Cancer Institution in Netherlands. Apart from the OVIHIPEC 1 trial, which she and Henk and all of them presided over, which was a practice-changing paper, she's also awarded the ISSP, that is the International Society of Study of Pleura and Peritoneum, Prize 2019, which is very prestigious for her phenomenal contribution in the field of peritoneal metastasis. She has a number of publications. The work would actually speak about her. We are eager to know how we are going to apply the trial she presided over in real world. And then we are going to take the question and answer. Over to you, Professor Wilhelmine Mandriel, and welcome and thank you very much for accepting our invitation.
Well, thank you very much for your kind words and kind introduction. I would like to thank Professor Somashekhar, but also the Vattikuti Foundation for organizing this webinar, which is organized very well. Thank you very much. So in the next 20 minutes, I will discuss the role of HIPEC in ovarian carcinoma. But as I said before, I think it's admirable that within this COVID era, this whole webinar is organized, but also that so many participants are present. So thanks a lot for everybody's interest. I've got no disclosures except for the fact that the Dutch Cancer Society and Zon and Wei financed the OVIHIPEC studies. And let's get right to the issue of my talk. First, I would like to address the question we currently face when we think about the role of HIPEC in ovarian carcinoma. There is still a lot of questions, and I will try to address them one by one. So first, why do we need HIPEC? When should we apply it? Which drugs should we use? And where should we perform the HIPEC? And how should we perform the procedure? So first, the rationale, and I think Henk already elaborated on this, but this is very briefly. We all know that ovarian cancer is diagnosed usually at a late stage when the disease has spread to the peritoneum in 70%. And the benefit of HIPEC is that it targets the site where the disease is. It's an intraoperative procedure, and we can give a high concentration at the site of the disease while we limit the systemic exposure. So we can give much higher doses than we would be able to give when we give the drug systemically. So why is HIPEC effective? Well, it has a direct lethal effect. It also enhances cytotoxic effect of the chemotherapy. And as you can see here below, the hypothermia improved the tissue perfusion temporarily by vasodilatation, but also by increasing the cellular uptake, which is shown by Zivanovic already 7 years ago. Over here, you can see a very nice schematic drawing, which was just recently published beginning of this year by Dellinger, showing the effect of heat on the various immunological processes. We also know that hypothermia inhibits DNA repair, which especially in ovarian cancer is of interest because we all know that the PARP inhibition is very effective in patients. So in patients with ovarian carcinoma. So there could be a room for combining hypothermia and PARP inhibition. So then when we come to the question, how should we perform HIPEC? Open or closed technique? Well, as there are no comparative trials, and usually the choice to either, the reason why hospitals make the choice to either perform an open or a closed technique is mainly because of health-related issues for the theater staff. So I know in the States, it's usually a closed technique. In France, it's open or closed. In the Netherlands, it's all open, but we don't have any comparative trials. And if you look at the theoretical background, then I don't think we can really say that one or the other technique is better. So then the question about dosing, should we use a concentration-based dose or a fixed dose? the concentration-based dose is related to the size of a person, BSM. And actually, we don't really know the answer to that either. Usually the trials which were performed or the retrospective studies which were done show a big variation in drugs, but also in concentrations and how it's used, but it's very difficult to draw any conclusions from that. So that's still a question I think we need to address to optimize this part of the HIPEC treatment. So then the question of where should HIPEC be performed? As Ruby mentioned, in the Netherlands there are 10 centers who perform the HIPEC. HIPEC is a complicated procedure. It's combined with extensive surgery. So in our opinion, if you want to start the HIPEC program, then you should be able to perform a minimum number of procedures annually. In order to get the experience, you need to perform this procedure with a minimum of toxicity and complications. And you should have a multidisciplinary HIPEC team in place, involving gynae-oncologists and GI surgeons, anesthesiologists, theater staff, and nursing staff on the ward. But also, when you perform HIPEC for ovarian carcinoma, the treatment team should definitely have experience in the treatment of ovarian carcinoma. And it's very important to complete the PDCA cycle to evaluate the results of your own HIPEC procedures. So I think that if you want to think about starting a HIPEC program, then these are all issues which should be taken into account. So then, which drug should we use? Well, if you look at the ideal candidate, then it should be biological active against the disease we treat. It should also be an active and a stable form when you use it during the HIPEC. It should have a direct cytotoxic effect without being cell cycle phases non-specific or without being specific. It should have a minimal local and systemic toxicity. And ideally, there's a slow absorption from the peritoneal cavity, and it should work synergistic with the hyperthermia. And it also should penetrate the tissue adequately. And based on all these requirements, cisplatinum theoretically is the best candidate to use in the during the HIPEC. So if we come to the trials which were done, there are a number of close trials which were performed at for primary disease. The OVIHIPEC 1 is already discussed by Henk, so I won't go into detail about that. The other trial which was done and presented at the ESCO in 2017 was performed by Lim et al. From Korea. They had 185 patients with either stage 3 or stage 4. Patients were eligible for the study when they underwent primary cytoreductive surgery or interval cytoreductive surgery. It was a different population, namely Asian, as compared to the Western population in the OVIHIPEC 1 trial. And the dose of cisplatinum was lower, 75 milligrams per square meter, whereas in the OVIHIPEC we used 100 milligrams square per meter. For the primary subgroup, the subgroup of primary cytoreductive surgery, there was no difference between the control arm and the HIPEC arm. But for the interval debulking surgery group, there was a tendency showing a benefit in the HIPEC arm. Then for the other condition, the other time of disease, the HIPEC during recurrent disease, there are 2 studies which have been finished already in the last 2 years. One is the HIPEC study, which was performed in France. I will go into detail later on, but I'll first discuss the details of the study from Memorial Sloan Kettering, which was presented by Zivanovic last year at the ESCO. Patients with the first platinum-sensitive recurrent ovarian carcinoma who had at least 6 to 30 months platinum-free interval. They were randomized during surgery, either in surgery without HIPEC or surgery with HIPEC. And during the HIPEC, carboplatin was used as a chemotherapy. The procedure took 90 minutes, and following the surgery, patients either received 6 cycles of IV postoperative platinum-based chemotherapy, and the HIPEC arm received 5 cycles of IV postoperative platinum-based chemotherapy. And this difference was done. So in general, all patients received 6 cycles of chemotherapy. So if you look at the results, well, both groups were balanced for the basic characteristics, as you can see here on the left side. And I will minimize myself. Yeah. If you look at the surgical results, then the number of complete site reductions, as you can see here in the blue graph, is the control arm. The orange bar is the HIPEC arm. There are slightly less patients who received a complete site reduction in this trial. And there were also less patients who underwent bowel resection in the HIPEC arm. If you look at the survival curves, then it's clearly visible that there's no difference in survival, either PFS or overall survival, between the HIPEC arm and the control arm. And whether that's explained by the fact that the patients in the HIPEC arm had a slightly less percentage of complete site reduction, I think that's very difficult to say because the numbers of patients are relatively low. But I think you can conclude from this trial that the HIPEC for this group of patients with carboplatin is not effective. Then the HIPEC study, which is a randomized controlled trial performed in France. In the beginning of this year, this trial was completed. Patients with the first relapse of more than 6 months were treated with neoadjuvant chemotherapy, and following an assessment whether they were responding to the chemotherapy, they had an additional 3 cycles, after which they were included in the trial. And at that time, they were randomized between surgery plus or minus HIPEC. And for the HIPEC, 75 milligrams per square meter was used for 60 minutes, an open or closed technique. So since this study is just finished, we have to wait for the final results. And that will probably take another 1 or 2 years. So then, what are currently the ongoing studies? Which I think it's great that there are so many randomized controlled trials going on, because in the end that will give us an answer what the place of the HIPEC should be. And I will highlight 2 of them. The lower ones, the HIPEC 04 and 03, are slightly different design. They're both from Chinese studies. They're already going on for some time, but that's the primary or interval site reductive surgery plus or minus post-operative HIPEC. So after surgery, patients are going to the ICU and then they get the HIPEC the day after. And they use docetaxel and cisplatin. For the 2 studies I want to highlight is the HINOVA, which is an Australian study. And they look into the question, is hyperthermia really necessary? So here's the design of the study. It's patients who are treated with neoadjuvant chemotherapy. They undergo surgery and they are randomized between either performing HIPEC with cisplatin 100 milligrams per square meter, or NIPEC, which is the HIPEC but without the hyperthermia. So that's the temperature of 37 degrees. Then following this procedure, they get an additional chemotherapy, and the outcomes are safety and feasibility, quality of life, and the costs, and the progression-free survival and overall survival. So the sample size is calculated based on the side effects, estimated grade 3 to 5 rate of adverse events, and they need 80 patients to complete this trial. Here is the primary endpoint. So it's mainly directed to the presence of adverse events, and the secondary endpoints are listed here. So this study started beginning of this year, and is they are enrolling patients at the moment, and it's all performed in Australia. Then the HIPEC study, which is a French study, it's also an interesting study. They will need 432 patients. With respect to the HIPEC, they use the same protocol as in the OVIHIPEC studies, and they randomize at the end of the cytoreductive surgery. So patients are either treated with primary debulking surgery and are randomized at the end of the surgery in HIPEC or no HIPEC and get their adjuvant chemotherapy, or the second group, the patients who receive neoadjuvant chemotherapy, and following 3 cycles, they are randomized with HIPEC, between HIPEC or no HIPEC, and they get an additional 3 cycles. So there are also a translational research component, and there's a stratification for disease burden, the residual disease following surgery, timing of the surgery, so primary debulking versus interval debulking, and the histological type, which is high-grade serous versus non-high-grade serous. So this study is running in France as well, and will probably run for the next couple of years. So these are the primary endpoints, which is disease-free survival, and the secondary endpoints is overall survival, safety, time to adjuvant chemotherapy, and the quality of life. So if we come back to the questions we addressed at the beginning of my talk, well, if you look at the question, why should we want to use HIPEC in ovarian carcinoma? Well, we all know that the survival is still very poor. The 5-year and 10-year survival is relatively low, even if in the era of the PARP inhibition. And I think we should try to use everything what is possible to improve the outcome of these patients. So when should we apply it? Well, during interval cytoreductive surgery for those patients for whom primary cytoreductive surgery is not feasible because there's too much disease. Those patients are eligible if they have FIGO stage 3. For the primary cytoreductive surgery, that's an answer which still needs to be answered. The trials are in progress. And if you look at the recurrent disease, well, I think if you look at the trial from Memorial Sloan, at least it's not effective with carboplatin, and we should wait for the result of the HIPEC study. The question whether you should use it per-operative or post-operative will probably be answered by the Chinese studies, which are currently ongoing as well. The theoretically advantage of the per-operative is that you don't have any adhesions, but maybe if you perform it 1 day after surgery, then those adhesions will not be limiting. So which drug should we use? Well, I think on theoretical grounds, cisplatin is the most logical one. We know from the taxanes that they are very that the influence of hyperthermia is limited and has a very small window, which is difficult to use in clinic. Then the question, where should we use it? I think it's important that centers who perform HIPEC should be experienced and should have a whole multidisciplinary team supporting the HIPEC program. And how should we use it? Well, open or closed, I don't think we will ever get the answer if there is a preference or if one is better than the other. And regarding the PIPEC, we just heard an excellent talk of Naul Bakrin about the place PIPEC currently has. So, well, regarding the OVIHIPEC 1 and 2 studies, that could never have been possible without the collaboration with a lot of colleagues, for which I'm very grateful that they are participating, and of course all the patients and their families. So thank you for your attention.
Thank you, Professor. That's a fantastic talk. There's a slide we all need to borrow for students and fellows teaching. It's a fantastic, analysis, including the recent trial from US group on carboplatin, which is hotly debated in India in all the groups. It's a beautiful, very well balanced talk, not taking side and not putting personal bias. Thank you very much for that outstanding talk you gave. It's really beautiful. I wish we can have a 45 minutes oration on that from beginning to end. Thank you very much for you and your group to having really agreed to take our invitation. Thank you very much. I invite Professor Dr. Mahendra Bhandari. He need to leave somewhere. I request him to give a message and little bit tell about the Vattikuti Foundation and its activity.
I'm sorry to interrupt, but because I have a flight to take, so I would really take your indulgence for a minute and personally thank Dr. Henk, Dr. Ruby, Dr. Lott, Dr. Noah Bakin, and Dr. Bhandari for such a wonderful discourse you had put it together. Well, if a surgeon can understand the intricacies of how the tumor biology works, it was a perfect example of what we should be doing. Creating such a great evidence which influenced the policy in the Netherlands and encouraged other countries to fund such trials for the benefit of patients. It is amazing. Hats off to you. And Vattikuti Foundation, just to tell you, is Vattikuti Foundation is organization which is our motto is to leverage technology not for hype but for the patient outcomes. And we have been in field, and it is to be credited for bringing robotic surgery to the world at our flagship institute, Vattikuti Urology Institute. And subsequently, we have a huge network, and now we have taken the plank of educating surgeons, because these were two mottos we learned by global dissemination of robotic surgery, that any technology is a specialty within a specialty. It should not be taken as a technique. Everything you have to look in terms of translating patient outcomes. And we have a huge network which is so supportive of patient education, and we have not deterred because of this stupid unseen enemy we have in terms of COVID. So I'm really appreciative of your effort, but anything you do good comes with a price. And don't be hesitant if I invite you again for yet another course for us. And I would thank Somashekhar for putting such a great program together. Now I know why he took so much of time and pause since I called him several months ago. Dr. Somashekhar, wonderful, and it was so good, and you brought the best in the world for the benefit of people. And let me tell you, this is the largest attended webinar we have, wherein even at the close of 2 hours, we have close to 200 people listening to you, and you can go on and go on. And I just thank the supportive collaborating organization for accepting and not letting the politics and bureaucracy come in to not to let it happen. Thank you very much, and I'll beg your leave. I apologize for leaving in between, which is so engrossing, but I learned a lot, because this is something I had myself a lot of questions, but I wouldn't really take away the rights of the participant because they are rightful. Thank you very much, and look forward to talk to you again. Thank you.
Thank you very much, sir. You are always there. Education and you are synonymous, and you are allies between US, Henry Ford, Vattikuti Foundation, and India. Thank you very much for your support, not only in this, for disseminating and bringing the robotic technology to the most needy in the second tier, third tier city. Thank you very much for making time, and have a nice flight. We would now take a lot of questions. The chat box and question answer is flooded. So I know that my panelists would be very busy now to do that. Thank you. What I would do is I've compiled all the questions, so I'll keep all the speakers busy. Before that, I'm going to unmute Dr. Vijay Ahuja, who is the president of OVIHIPEC. Sir, you're unmuted. Your few words, and then I'm going to go to question and answer session. You can speak. I've unmuted you. Vijay, sir. Vijay Ahuja, sir.
Yeah, thank you, Dr. Somashekhar. Thank you for giving me an opportunity to have been a wonderful session to have all the luminaries in the field of HIPEC talking to us directly. And as we know, in India, HIPEC, you have been pioneering this technique. And we have, as I say, believers and non-believers in India. So the believers swear by it, and non-believers just say that it may not be something worthwhile. So this sort of a session really opens our eyes and widens our horizons. I really thank you for bringing this program and involving Agoy in it. And we are looking forward to the interactions, and most of our doubts, I'm sure, most of the non-believers will come to the side of the believers after this session. Thank you, Dr. Sohn.
Thank you very much. So before I go ahead with this particular thing, there are two people, I think, who has raised the hand. So I'm going to unmute them. Rupinder, are you there? Can you speak?
Okay, so first of all, good evening, everyone. Thank you, Dr. Somashekhar, for bringing such luminaries on a single platform so that we can share their knowledge. We have been doing a lot of HIPEC, like you said, but we too have now been able to see some different aspects of both HIPEC and PIPEC, and we hope to introduce them into our practice as well. And as you can see from the results, such evidence-based talks, and like what Dr. Vijay Ahuja said, I think soon we are going to have a lot of non-believers turn into believers. Thank you so much. Looking forward to the question and answer session.
Thank you very much. Okay, now what I'm going to do is I have Dr. Rajiv Das who have lifted his hand. Please go ahead and ask your question. Keep it crisp, no comments, just a question, keep it crisp. And you can also introduce yourself and address to whom this question is. So Dr. Rajiv Das, please go ahead. I've unmuted you.
Yeah, Dr. Somashekhar, it's a very nice talk and a nice lecture, and so many luminaries and they presented the talk in such a lucid manner, and it's also much important data. So thank you once again. Thank you for the training you.
Thank you. You can go ahead with your question.
Yes. No. So now, actually, my question is this regarding PIPAC versus HIPEC. So, any role do you? I mean, this is just a hypothetical question. Do you think in times to come, PIPAC would replace HIPEC, considering the level of penetration, the level of toxicity, and the more effectiveness with the lesser dose? So I was just wondering, are they eminent panelists?
Thank you. I understood your question. I will allow first Professor Bakrin, then Professor Vandriel to answer. The question is, do you think since the penetration and efficacy of PIPEC by the science is much better than HIPEC, do we see that PIPEC is going to replace HIPEC in ovarian CA in any time in future?
No, I don't think so. I think that we have to fight against this idea, because PIPEC and HIPEC don't address the same population. In HIPEC, we address a population with a curative intent, and the HIPEC is just a complement to, it's just an addition to surgery, a great effort of surgery, while PIPEC is only a way to give chemotherapy. So we can't see them as concurrential. We have to see them at different time points of the lifetime of patients with ovarian cancer.
See, it's very important for audience not to get carried away. HIPEC is combined with cytoreductive surgery, so it is a curative treatment. PIPEC as of today is a palliative treatment. However, neoadjuvant PIPEC and cytoreductive surgery are being explored, not high-level evidence. Professor Vandriel, what is your thought process on this?
Well, I think I agree with Naul in that case that we don't really know how PIPEC and the CRS can be combined. So I think you have to be very aware of the complications which could come up. And we first really need evidence and proof that it's safe before we could really compare it. So I agree with Naul, Professor Bakrin.
He is a very senior gynecological oncologist who was serving Indian Defense, and now he is in a Max Cancer Center in New Delhi. Very senior executive member of Association of Gynae Onco. So Manas, please go ahead and ask your question. I unmuted you.
Yeah, it was about the last question which was asked, whether PIPEC will replace HIPEC. Actually, I think the question should be that whether the technique of PIPEC would replace HIPEC in the same circumstance. You see, you do a closure and then use PIPEC, because pressurized chemotherapy could be even more effective in a raw, deperitonized abdomen. So is there a role? Can this technology come in?
Professor
I
Bakri?
understand. Yeah, I understand. At the beginning of the experience of Marc Raymond, who invented PIPAC, they tried to replace HIPEC by PIPAC, and then they performed CRS, and then they performed PIPAC. And there was a very high rate of complication, of toxicity, but also of mortality, that made them have a step forward. And then they decided not to perform any more PIPAC after CRS. And this is so important that when we have, for instance, we can't perform any surgery before PIPAC. If, for instance, when you penetrate, you make your laparoscopy, and then you have a wound on the colon or in the intestine, so you can't perform PIPAC in the same time, because we assume that there is a huge risk of complication. So up to date, as far as we know, we can't at this time perform PIPAC replacing HIPEC.
Serosal tear, or if you need to perform a bowel anastomosis, PIPAC has got very high concentration and pressure. So the safety is, after a cytoreduction, is not proved. New evidences are arriving from Russia, where in gastric cancer they're trying to do, but as of now, we need to be very careful to do that. So what I'm going to do is, I have compiled all the questions. It is sometime addressed actually already by name to whom it is. If it is not, then all the panelists are most welcome to go ahead with that. So the first question is to Professor Henk. Why do we choose HIPEC temperature between 40 to 41 degree? Is that the only recommendation? This question is from one of my colleague, M. Ray. He is a HIPEC surgeon from All India Institute of Medical Science. He and team of Dr. S.V.S. Deo have done over 200 HIPEC in peritoneal surface malignancy. Professor Henk, to you.
And thank you for the question. Well, when the study was designed, it was quite a while ago. I think the 41 degrees was the optimal temperature for the cisplatin to work. And well, we haven't changed it until now, I think. And I know in the Dutch Cancer Institute, one of the PhD students is looking at the stability of the drugs like carboplatin and cisplatin and the temperature. So perhaps we have some new insight of this temperature, but we still remain the temperature as the initial set temperature in the OVIHIPEC 1 trial for now. Do you have any comments for that, Willemien, still?
No, I think you're absolutely right. I think the HIPEC as performed by the GI surgeons at the time the trial started, that was just common to use between 40 and 41 degrees. So that's the reason why we included that in the protocol.
Absolutely. So if we look at the phase 1, phase 2 trial, the effect of hyperthermia starts potentiating the action of chemo by 39 degree, and it peaks between 41 to 42. the moment we cross 43°, the bowel complications are very high. So it was found that we need to be above 39, but never above 43. So 41 to 42 is found to be the most optimal, balancing the efficacy and the complication. The next question is from our Bangladesh colleagues, Professor Janatul. She is from Bangladesh. As you know, for this webinar, we have people worldwide who have done Philippines, UK, and USA and India and Bangladesh, everywhere. This question is, why requirement of stoma in HIPEC group? So I think to both Henk and Wilmin, was there high chance of stoma in HIPEC group, or you think it was balanced in both?
Well, I think at the time we started with the HIPEC procedure, we were a bit more precautious. But you see in both groups, we had the same amount of bowel resections. They were in both groups 24%. So there was no difference in bowel resection in both groups in the OVIHIPEC trial. However, we performed more stomas in the HIPEC group. And I think that was partly because we were just more precautious at that time in the early days, because we didn't know exactly how everything would react on the HIPEC treatment. And when I look now, well, 10 years later, I personally think that we make less stomas now in the HIPEC group. At that time, we did it much more than at this time. I think we trust more to make a good anastomosis and then still perform HIPEC. I don't know. I feel that's shift personally in our clinic, and perhaps Willemien can say something about the Dutch Cancer Institute if they have also the feeling that they do less stomas now in the HIPECs.
Yeah, I think I agree, and that the pity is that we haven't asked during the OVIHIPEC 1 trial. We didn't ask for the reason why stoma was performed, so we will never get an answer whether it was precautionist or whether the anastomosis was under higher tension. And that will definitely be a subject in the OVIHIPEC 2 trial, so we will get that answer by then. If you look at all the studies, and mainly from the colorectal surgery, then there's no higher incidence of anastomotic leakage after HIPEC. So theoretically, there's no reason to be more cautious.
Absolutely. We have some answer from the Indian HIPEC registry. Over 2,000 HIPEC performed in ovarian cancer. We found that the stoma rate varied from 2.8% to 6% from institution, but it was no different now that we have learned in the last 10 years. And also now Professor Bakri knows there is a project which she and a colleague, Professor Oliver Glehen, is undertaking with currently globally, including my center, Manipal Hospital, Bangalore, assessing stoma rate and the reason in HIPEC. But in short, the answer is once you cross the learning curve of maybe 50 to 90, the stoma rates are no different. Now the next question is from Sarika Gupta. She's a gynecologist, oncologist from New Delhi, active member of OVIHIPEC. This is to Professor Willemien van Driel. You already spoke about this trial from Emory and Sloan Kettering. It was found that the secondary cytoreduction didn't improve the PFS. And what is your comment? I know you already answered it, but now that you can elaborate, do you think this is contrary to your OVIHIPEC 1, or they're two different patient subset, different drug used? Should we take it as a negative trial, or how should we infer?
Well, I think it's a different drug. Stressing the point that cisplatinum is probably the more favorable drug if we need to make a choice. It's a relatively small trial, so whether the difference in complete cytoreduction rate is responsible for the fact that the HIPEC arm is not better than the control arm, well, we will never know. Yeah, there's also a difference in IV cycles, and I think if you look at the concept of HIPEC, HIPEC is a combination of heat plus chemotherapy, and I think the IV chemotherapy you give, if you really want to see if HIPEC adds something, then the rest of the circumstances should be the same. So if I had to design a trial like this, then I will probably be more in favor of giving 6 cycles and then plus or minus HIPEC, because then you really know what the effect of HIPEC is additive to your standard treatment. And that's something that this trial didn't show, you cannot really answer, because the control arm received 6 cycles and the HIPEC arm received 5 cycles. So actually this trial tried to answer whether HIPEC is has the same effect as an extra IV cycle. And that's probably true. But whether HIPEC adds something to the standard therapy, that's not answered by this trial.
That's excellent analysis, actually. The next question is from Asima Mukhyavatai. She's my very close friend and colleague. She's currently based in UK. She is a great cytoreductive surgeon and an active member of IGCS and ESCO. A great friend of mine, a great scientist, not just a clinician, but also a basic science researcher in the lab. The question from her is, in India, we don't have sodium thiofluate, which is actually used in your OVIHIPEC trial, and you emphasized a lot. This was one of the reason nephrotoxicity of cisplatin didn't happen. So we usually use 70 milligram per meter square, this one, and this dose variation, is it accepted? But I can partly answer, if you see the Korean trial, which used 75 milligram, it didn't give a good result. I am also very skeptical using anything less than 100. But I let Henk and Glimin answer this question.
Yeah, I think there are more countries having the trouble or having difficulty to get sodium thiosulfate. I know in France they have to get permission for every time they want to use it. For the States, it's also difficult. And I know for another protocol which uses extra hydration when you give them 100 milligrams cisplatin. I think this also touches on the question, what is the right dose? Should we use a fixed dose, or should we use a concentration-based fluid? I think those questions are not really answered. The only thing is that if you look at all the IP trials, and if it's a HIPEC or if it's adjuvant IP chemotherapy, then all the positive trials use cisplatin 100 milligrams per square meter. It accounts for the Armstrong's trial and it accounts for the OVIHIPEC. So I think it's well, if there is an alternative and give extra hydration, then maybe it's something to inquire with the some hospitals in the US who uses that protocol. But I would prefer to use the cisplatin 100 milligrams per square meter, because we know that works. And you don't know whether, well, I think the less is probably less effective, but again, that's not really set in stone.
Thank you. Next question is to Professor Bakrin. If you encounter extensive adhesions while doing a PIPAC or a loculated ascites compartment, how would you actually proceed? Is it an absolute contraindication? Do you abandon PIPAC, or would you still proceed?
It depends on the adhesolysis you have to perform. If the adhesion are very soft and very easy to do, so I will perform PIPAC, and it depends also on the work chamber. You have to have a good work chamber, because if you have only a little or small work chamber, PIPAC won't diffuse to all the abdomen. So it's very to give instruction for all cases. But what I have to say is, if there is a wound or on colon or on stomach or on small intestine, you have to stitch it and to postpone the PIPAC.
Absolutely. If I would, let know the person who asked this question, if you go back and read the overview of the PIPAC done in all peritoneal surface malignancy by Professor Aliami, our friend Momo, which is published, more than 92% you are able to do successful peritoneoscopy, and less than 7 to 10% you abandon a procedure of PIPAC because of adhesions. So that's lost promising, and the same V2 address. So even though extensive adhesions can happen, but more than 90% of the time you can perform a successful PIPAC. Professor Bakrin, would you agree with that?
Yeah, I totally agree. And the more you are experienced in PIPAC, and the less you have non-access situation.
Thank you. The next question I didn't understand. It is from Upasana. How was the past defined in the OVIHIPEC trial? Hank, did you make out what is it? I didn't understand what this. How was the past defined in OVIHIPEC trial? It just came when you were giving a talk. Maybe I'll unmute Upasana later and ask what she meant. I'll go to next question. This is from my colleague, Dr. Rohit Ranade. Was the threshold to do stoma less in HIPEC? I think this is partly already answered. Williamin and Henk told that initially, first 5 years, they had very low threshold. As they become experienced, they understand that probably stoma is not required. Am I right, Henk? Is there anything to add in this?
Yes, I think you're right. That explains the difference. And in the non-HIPEC group, well, we do the normal criteria for feeling the new bowel anastomosis is under pressure or at risk. Then we put a stoma, but that is something you decide together as surgeons at that time. And I think in the HIPEC group, we were a bit more careful and made more stomas in the beginning. And now we see that it's, I think if we measure it now, it would be probably equal.
Absolutely. Thank you. Thank you. The next question is from Kavita Sukumar. Was recurrence defined in OVIHIPEC trial as a biochemical failure, that is CA125, or an imaging appearance like RECIST criteria based? So any one of you can take. I know the answer because I read this trial in between the lines a million times, but I would want the authors to answer this. Was it a biochemical failure, CA125, or was it a RECIST based on imaging?
Well, the recurrence were found by both because we at follow-up we did CA125 and we did at regular times we did a CT scan. So, and I think we found in the CA125 recurrence in about 13-14%, and the main group of recurrences was found at CT evaluations. So I think about 80% we discovered at routinely CT evaluations. So that's a practice we currently not do for our patients. In the Netherlands, we only do CA125 or radiology at the moment. The patients have complaints in their follow-up. So it's not a standard measurement at the moment. And that's followed by the ESCO trial we performed a couple of years ago. So, but now in the OVIHIPEC trial, we had set time and set measurements. So we found a recurrence also at times that the patient didn't have any complaints yet.
Thank you. That's one of the reasons when you compare the outcome of Scorpio trial to OVIHIPEC, there are two different populations. It's very important to understand. In OVIHIPEC, those patients who are amenable for upfront surgery actually underwent surgery. They're a good group. Only those who are not eligible for surgery, bad group were taken. That's why, because CA125 is used, biochemical failure are picked up very high, and that's why DFS was somewhere around 13-14 months and 36 months OS. Am I right, Professor?
Yeah. Yeah, I think you're right, and I think Henk explained exactly what we did in the trial. That we had either symptoms, patients had either symptoms for which we performed CO125 or CT scan, and at specific time points, the examinations were done.
Thank you.
Yeah.
So next question is from Upasana. How was actually this actually is a sequel of first. So the PFS was actually defined. So since CA125 was used, that's one of the reason PFS and DFS was short in the trial, which we don't do in real time. If a patient is fine, they're walking around, we are not going to intervene.
Yeah, perhaps
so
we can also add something that we started the PFS from the moment of randomization, and that is the moment of the interval debulking surgery. So we count from that moment, and we don't count from the date of the diagnosis or the first biopsy. So that is also a difference in our study.
Thank you very much. Hang, next two questions are from Dr. Rupesh, our colleague. He's a very good gynecologist, oncologist, senior, extremely qualified and very aggressive surgeon himself. There are two questions. What percentage of your patient who would do total parietal peritonectomy? You know where this question comes from. You know, my center is a strong proponent of total parietal peritonectomy. You have seen when you came to India. We don't make an entry into abdomen. We do a systematic total parietal peritonectomy like a parachute technique. And we have 4 publications from our institution showing more than 200 patients with a better overall survival in the group who had total parietal peritonectomy, and the pattern of recurrence was more extra abdominal, so it translated into both DFS and OS. But mine is not a randomized controlled trial, but we have 3 publications from my center. It is not a standard of care, but we in our institution we do total parietal peritonectomy, and as per our results. So what is I would ask this from both your group and also Professor Bakri. I can also rephrase, in which condition do you actually go for total parietal peritonectomy, and where would you do in-field selective peritonectomy?
Now, well, we have a different approach in the Netherlands, you know, and we only remove disease which we can see with our bare eye, and that we do also into, well, perhaps to reduce morbidity. So we do the debulking surgery, and we remove all the visual tumor, but we don't remove peritoneum where we don't see anything abnormal. And of course, we know that there can be microscopic cells in that peritoneum, but still left there. But that's also why we add the HIPEC treatment now to get those cells away. And well, we find a balance between morbidity and and survival, I think. But perhaps Wilhelmine has something to comment on that also. But it's
well, in the OVIHIPEC 1 trial, the majority of the patients underwent a complete cytoreduction. So it's had the numbers of patients who had minimal residual disease, so less than 2.5 millimeters, is really too small to make any comments on that. To say whether the HIPEC is more beneficial for those who don't have any visible disease, or those who have peritonitis. And I think I agree that in our center as well, we don't perform routinely a total peritonectomy. We only treat what is abnormal.
Yeah, because in this webinar, my 2 colleagues who are expert in HIPEC, Dr. Ashwin KR and Dr. Rohit, have joined. They presented a fantastic paper in PSOGI Paris meet, and they got the best paper award, which showed how the recurrence pattern can be changed by doing parietal peritonectomy. Now with Vic Verwal, we are about to initiate a randomized control trial. So maybe until that time, I think primary peritoneal carcinomatosis is the condition where you might do this. In all other ovarian, I think the current standard is infield. I agree with you. The time to start chemotherapy was quite longer in both groups, because we have a Japan trial which says if you delay beyond 21 days, it's going to impact every month. So this is from Rupesh. The time to start chemo was quite longer in both groups. Is it acceptable to wait up to 4 weeks and beyond? Can you enlighten us?
Yeah, well, we've got a Dutch, let's start with the OVIHIPEC 1 study. Had a difference in time to start adjuvant chemotherapy was minimal. It was 30 days for the control arm, 33 days for the HIPEC arm. And that reflects standard practice in the Netherlands. And we evaluated the results regarding starting chemotherapy following surgery and survival of our Dutch cancer registry, which is a registry which goes way back, 30 years back. And there the tipping time had to reduce or had to have an effect on overall survival was 29 days. So I think that had to start the adjuvant treatment, it would preferably be around 29 days in order to have to not have a negative impact on the survival. And that's exactly what you aim to do with your surgery, cytoreductive surgery and your HIPEC. You want to minimize the complications, which causes delay in restarting your chemotherapy.
Actually, we especially looked at delay in chemo, and Dr. Ramya and Dr. Rohit and Ashwin, they have published in Pleuron Peritoneum. We looked if there is a delay in the adjuvant first line chemo because of whatever recovery reason. We found that up to 40 days, if you have done a HIPEC, which acts like one dose of chemo, there was no impact on overall survival followed up to 5 years. If you have done a cytoreduction alone, anything beyond 30 days had an impact. So we have a paper where delay in chemo impact in HIPEC and non-HIPEC group. It's very interesting. You can go back and read that. And when we had done HIPEC up to 40 days, it was okay. When it is 30 days for non-HIPEC group. The next question is to Professor Bakrin. This is from Dr. Revan, surgical oncologist from Hyderabad. Gas is better than liquid. Gas is PIPAC, liquid is HIPEC. So don't you think PIPAC at some way you can, I know you answered already, but would you sort of take this question, Professor Bakrin?
Yes, of course. I would say that PIPAC looks like gas, but it's not exactly, it doesn't react exactly like a gas, because when you look at the distribution inside the peritoneal cavity, you see that there are some heterogeneity in the distribution, and there are, for instance, more doxorubicin just next to the capnopen, and less doxorubicin when you go far from the capnopen. And I would say that it looks like a gas, but it doesn't act exactly like a gas. This is the first part of my answer. And I think the second part I would repeat, because I think it's a very important message, and it's very important to take into account this data. I think that up to date, we can't offer CRS and PIPAC to our patients because previous experience show a huge amount of toxicity, and if we want to, we have to assess it into a trial. Even if I know that some data from Russia and gastric cancer are quite promising and positive for this association.
Thank you very much. The next question is from Professor Yudi Bafna. He's a senior most gynecological oncologist from a regional cancer center from Bangalore, India. He's a professor, and hundreds of people have been trained under him. Excellent surgeon himself. I have unmuted you, Bafna. Can you go ahead and ask your question directly, please?
Yeah, my question is to Professor Bhandari. I would like to ask you, between no HIPEC and HIPEC groups, the non-HIPEC group not only had one cycle of chemotherapy less, but the duration between the third cycle and the fourth cycle also was at least 3 weeks before the surgery and 30 days after the surgery. So very long time with no chemotherapy in non-HIPEC group. So don't you think it is unfair to compare these two groups under such circumstances?
Well, I think that's, if you want to find out what the extra effect is of HIPEC, then you should compare a group receiving HIPEC with the standard therapy. And the standard therapy is as it is. It's neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy, which it includes 6 weeks of no chemotherapy between the third cycle and the fourth cycle. And adding HIPEC, the HIPEC is a treatment consisting of cytoreductive surgery, rinsing the abdomen with chemotherapy and hyperthermia. So if you want to find out what the effect of HIPEC is, then this is the design you should do. If you want to compensate for that, then you will never find the answer what the effect of HIPEC is.
Absolutely. And we have now the trial which has surgery with normothermic wash and hyperthermia. Probably that will clearly answer. Yeah. Many people say hyperthermia roughly adds 4% extra benefit in animal model. If you see, we need to just check that. Thank you very much. The next question, I think you can take carboplatin, cisplatin. Is carboplatin stable at 41 degree? We know cisplatin is stable at 41. But isn't carboplatin a good intraperitoneal drug with less toxicity? Why it's failing?
Well, I think the active, once you administer the cisplatinum in the, or carboplatin in the abdomen, then the active form of cisplatinum stays longer in place than the carboplatin, which is the reason why the cisplatin is a more favorable choice.
Thank you. Thank you very much. I have a question from Asima. I'm a great admirer of Asima. I've unmuted you. Asima, can you go ahead and ask a question? You have written one caution is the success of HIPEC should not push everybody to interval cytoreduction, where even now we know if we can cytoreduce upfront, it can never be equivalent. Asima, can you go ahead and ask your question? I unmuted you.
No, it's just a comment, really. I think the success of HIPEC, because we don't have the results of the HIPEC with primary surgery yet, but people should not be thinking that it's a time to really go more and more neoadjuvant chemotherapy and just compensate with HIPEC, because it does require quite a lot of effort to put up a primary cytoreduction program. I think what I'm trying to say that sometimes in centers, and that's just based on my experience and talking to a lot of people in the field, when you have centers who are really doing 70 to 80% neoadjuvant chemotherapy and interval debulking surgery, it sets up a culture such that your primary surgeries are also more or less look like your interval debulking surgery. Whereas when you have a culture setting where majority of the patients really, I think if they're fit, they should go for primary surgery, then your neoadjuvant chemotherapy patients also have a better surgical quality. So it's just a bit of a caution that people should just not think that we have a solution to do more and more neoadjuvant chemotherapy, but that's a personal opinion, I think.
So I would request Vantiel to take this question, and there is one more question from Tapan Chauhan.
Can I comment on this?
Yes,
because I think you're absolutely right. And I think if you have your NDT, you discuss patients, then it would be, very good to have a system in place where you can objectively decide that this patient has too much disease on board to get an effective primary CRS, for instance, based on the trust criteria and the whole clinical picture. So you can objectively have some reasons why you go for the primary CRS or for the neoadjuvant chemotherapy. In that way, you can prevent that patients get neoadjuvant chemotherapy in those cases where primary CRS would be very good possible.
Thank you. Until your OVIHIPEC 2 trial is complete, can we offer HIPEC with CRS in upfront primary site reduction? This is a question from Tapan Chauhan. What's your thought process? Yeah, our trial would take 5 years to recruit, 5 years to wait, 10 years, and then I think our surgical career is out, our next generation. So what do you think? Is it time to offer upfront CRS? Because, if it works, it would definitely work the best in upfront. I don't know. What is your thought?
Well, I think that's an ethical question. And depends very much on how quick you want to implement new strategies which haven't proven to be active yet. The same goes for surgery for recurrent disease. We've got a desktop trial. We're all very anxious waiting for the final results. So we know the preliminary results. We also have the TRUST study, which will give an answer on the question whether primary CRS or interval CRS, which of the one is better. So I think it's a difficult question. We all want. I think in medicine, I think we tend to think that if you do more, then it's better, and I'm not sure if that's always the case.
I think the best thing is to write a protocol, get a IRB approval, and then do it as a part of it, which we have been doing in my center. So which we have been doing out of the entire HIPEC for ovary, more than 200 in our center are upfront, and it is not a randomized trial, but when we compared, we had a best result in upfront. Maybe a bias of case selection, so only a randomized control trial can answer. There is one question from Bangladesh, Professor Shahana. What is the rate of reoperation in your HIPEC group? This is a misnomer people have. HIPEC is very toxic, quality of life comes down, a lot of patients end up with multiple re-exploration obstruction. I would recommend everybody to go and read the quality of life paper also published from OVIHIPEC. First, it was presented in ESMO. I was there, I heard that firsthand, and then it is also published. But I would tell Henk, what is your answer? You have presided over and now taking over the upfront surgery, OVIHIPEC 2. Is reoperation rate in HIPEC group more?
Well, I don't think we have a bigger rate in the HIPEC group. I don't know exactly the date for reoperation, but in our hospital, I can think there was no difference between HIPEC or non-HIPEC. Perhaps Willemien knows the data exactly, but
well, I think to be honest, we didn't report the Clavidindo classification. So I think we really have to go back to the data to look this question to look for the answer to this question. We used the CTC adverse event scale, and there was no higher percentage in anastomotic leakage or bleeding or post-operative bleeding. So from that, I think there was no difference in reoperation rate. And in addition, there was no difference in reinitiation of the chemotherapy. So I don't think there is a huge difference in this respect.
I would request Professor Bakrin to step in, because a very large volume from her and Oliver Glehen group has actually been published, the morbidity and mortality. From what I analyzed from our Indian HIPEC registry, the morbidity mortality is high only during the learning curve. HIPEC is something which has got a long learning curve, unlike any other surgery. So once you pass the learning curve, it was same for us. But in learning curve phase, definitely morbidity was little high. But Professor Bakrin's, most of your publication I have read. Can you please throw a light from French group?
Yeah, I totally agree with you. I don't think that there is more reoperation in HIPEC group compared to CRS. but I think I can't answer honestly concerning the learning curve, because as in our center, we treat patients from other origin, from peritoneal carcinomatosis, rare diseases, pseudomyxoma, etc. Our learning curve is far away. So we will be able to answer, because we have there is an implementation of HIPEC in a new team, and we are studying their learning curve, and then we will be able to answer with the data. But as far as I know, there is no difference in our practice. So it's not trial, but in our practice, there is no difference in the reoperation between HIPEC and non-HIPEC patients.
Absolutely. And for all the delegates, I would welcome you to read Professor Kusamura Shigeki's papers. The largest work on learning curve and HIPEC is from NCI Milan. My very close friend, Professor Shigeki Kusamura, along with Marcelo Daraco. A lot of insights for people to start the learning curve is there. My colleague, Dr. Ashwin and Rohit, tried to put a learning curve for my group, and they just couldn't put, because last 20 years over 1,600 cytoreduction group of our surgeons had done. We don't know where the learning curve of cytoreduction ended and where the learning curve of HIPEC began. And even today, Dr. Rohit is never able to put learning curve. Everything has to come to end. There are 100 questions. I would probably end this with this question. You say 2.5 millimeter CC0, CC1. How is it like? A scale, a magnifying glass, or, oh, okay, two surgeons agree, nothing seen to my eye. I know that, Dr. Amita has asked this question. A lot of people have asked, how is this 2.5? Just you agree? Or you're going to measure it?
It's a historical way to measure the residual disease. But I think that what we all know as surgeon is that this CC1 apply particularly, for instance, when you have a huge amount of tiny nodules on the mesentery, and then you try during hours to clear it up. But honestly, you can't say that you don't have forgot one nodule, and that's the reason why you say CC1. But in reality, I don't think there is a situation where you left really 2.5 millimeter of disease. What is your opinion, Professor Somashekhar?
I will request Henk and Wilhelmina to answer, then I'll take it. Because we practice total peritonectomy exactly for that reason. And I would request both of you, Henk and Wilhelmina, to answer this.
In general, in the Netherlands, well, we say optimal debulking will be less than 10 millimeters. But we make a differentiation between those. We go down to 5 millimeters, and we go down to 2.5 millimeters. And what we actually saw, I think, in the OVIHIPEC 1 trial was that the HIPEC performance was better in the patients with 2.5 millimeter residual diseases than the, for instance, 7.5 millimeter disease. So that is actually perhaps a different identity, as Professor Bakrin just mentioned. Those very tiny little nodules for 1 or 2 millimeters, which you can't remove probably everyone, but you can manage them perhaps with the HIPEC. And that's also why we included this difference now in the OVIHIPEC 2 trial. Wilhelmine, do you have something to add?
Yeah, I think if you look at the OVIHIPEC 1 data, then the numbers are too small to draw any conclusions if there's a difference in less than 2.5 millimeters or less than 1 centimeter. And what we implemented in the Dutch registry is the PCI score, which forces everybody performing cytoreductive surgery to note down, to record the amount of disease left following the surgery in every region. So I think if you've done a lot of these CRS procedures, then you know when it's 2.5 millimeters and when it's a centimeter and when it's 2 centimeters. It's and what we notice in the implementation phase is that that's also a very good way to standardize the way you evaluate the abdomen after the surgery. So I think in the Netherlands, by the end of this year, everybody will do this the same.
Absolutely. It's very important to understand a unit which runs HIPEC program. Practically everything in the abdomen is cytoreducible. The only limiting factor is nodules on the small bowel. So you can't end up with short gut. So what we normally evaluate is if small bowel is the only place where miliary nodules are going to be left behind, I would go all out in ponta hepatis, lesser, omental bursectomy, everything. And then I would accept it as 1 to 2 millimeter on the bowel, and still I know HIPEC would help. So don't try to use this 2.5 millimeter on a parietal peritoneum or a Gleason capsule or a diaphragm or in a pouch of Douglas. They're all cytoreducible. If you've done full maximum cytoreduction and the only miliary nodules are small bowel, and you can't end up, we know that more than 3 bowel resection is a morbidity factor in HIPEC. I would then accept that as 2.5 millimeters. That's the only place I would accept. Every else where effort can be translated. Professor Bakrin, do you agree with this philosophy?
I totally agree.
Thank you. Thank you very much.
It has to be reserved to places you can't cytoreduce.
Yeah, I agree.
Thank you. I have to end it. It's never going to end. And then my Dutch colleagues will next time never accept my invitation if I keep going on, and then Professor Bakrin would be thinking, this is much more than a cytoreductive surgery happening. I profoundly thank on behalf of Vattikuti Foundation, Indian Society of Peritoneal Surface Malignancy, Association of Gynecologists Oncologists of India, to my Dutch colleagues, Vandriel and our colleague, Professor Henk, my great friend who loves Indian spicy food for a change, and Professor Bakrin. Out of all the odds, you bet the odds, and then you did a fantastic talk, and all the delegates, and we had 500 registration. Thank you very much for this, and what a wonderful event and effort it had been. It's pleasure. I hope we can host all of you in India live, not just academics. We mix fantastic Indian hospitality. Thank you very much, and I will just give few last parting lines to Wilhelmina and then Henk and Bakrim, and then I'll end this program. Please go ahead, 3 of you, one after the other.
Well, thank you very much. It was a great pleasure. I had a wonderful afternoon, and I think a lot of interesting discussions went on. So thank you very much for hosting this.
Thank you.
Yes, thank you, Somu, for hosting this, and also the Vattikuti Institute. Great to make this possible. And I think it's quite unique that we have so many participants with actually the same interest on this really interesting but small topic in the world, because all the people who are actually here were really interested in HIPEC, which is great to see. Thank you all.
Bakrin, I'm greatly fascinated with the work Bakrin has done. I would request everybody to visit ResearchGate and see her work right from basic science to the clinical translation. And
thank you very much. Thank you for invitation, and thank you. It was a great opportunity for me to share with you my experience and to learn a lot from you. And I'm looking forward for the next event.
Thank you. And then I'm happy that today I received a letter from Professor Paul Sugarbaker that for the first time they've expanded the executive committee of PSOGI, and they've inducted me as a executive member, which is a very rare honor, and I'm very happy to share with my colleagues. And first time it is expanded, and then the EC committee invited me to be one of executive member. Thank you.
Congratulations.
Congratulations. Happy for you.
Thank you. Thank you. And Dave, over to you for parting, and thanks very much, Dave. Without you, it wouldn't have been possible. Fantastic evening we had, and India, it is now, time for dinner. And thank you very much, Dave. Over to you to end the comment.
Well, thank you everyone for an incredible program, an incredible master class. It's hard to imagine everybody getting together for so long and sharing so much information, and your audience stuck with you, which means that meant a lot to our attendees today too. So thank you. I also want to thank Dr. Van Stein and Dr. Ronson for their part in this. Thank you and goodbye.
Thank you very much. All of
Thank
you.
you, Dave, for making this possible.
Yeah, thanks.
Thank
Bye.
you very much.
Bye.
Well, have a good weekend all.
Yeah, nice.
Time for a cold beer, I think now.
It was very,
Definitely.
500 people registering, and this is never going to end. And you know that if you come to India, it would go on for 5 hours and you will never sit. And even when you go for a dinner, 100 people would come, keep asking questions. And India is known for good hospitality, and then they will take all the knowledge and they want to interact. Hank, thank you. My personal thank you for all the effort you did. Great. Thank you very much. Thank you.
Well, thank you for organizing.
Next time we come together to India.
Yeah, to India. Yeah, that's a good plan. Yeah.
We have so much to say now.
Thank you. Thank you very much.
All right.
Have a nice day.
Okay. Bye-bye.
Bye.